Hello, I'm Carole Vetter. I'm an orthopedic surgeon, Department of Sports Medicine at the Medical College of Wisconsin. Today we're going to talk about examination of the athletic knee. We are also going to talk about the athletic shoulder. Specifically, with the athletic knee, we're going to concentrate on patellofemoral problems, ligament injury and problems, and cartilage problems. Examination of any knee is always a bilateral examination, comparing the non-complaining knee to the knee that the patient's complaining about. In a general examination of the knee, the first thing you want to do is inspection. You want to look for any bruising, any swelling, any obvious deformities of the knee. Comparing side to side. A very typical problem in the knee is going to be swelling. That's called an effusion. There's mainly two ways to look at an effusion. One is called a ballotable patella, where the patella is floating. And so when you push down on the patella, you can feel a sponginess or a floating of the patella. The second is a fluid wave, where we are going to push fluid out from the medial side and try and milk it back in. So it's a milking of the fluid around the knee such that you can see it wave back and forth. The next general examination of a knee is going to be range of motion, comparing involved to uninvolved. First thing you want to check is any hyperextension, or that the patient gets normal extension of their knee. This patient happens to have full extension with his leg lying, and then has some hyperextension. And I just want to check that that's the same. He has the same amount of hyperextension on both sides. And then the next is flexion. We ask the patient to flex up, and then we can do a little forced flexion, and we want to measure that. And anywhere in this area is about 140 degrees. Now we're going to go over an examination of a patient complaining of anterior knee pain. They'll often complain, if they have an anterior knee problem, of pain with sitting for long periods of time, pain walking up and down stairs, pain with squatting. Any of those are signs that they have an anterior knee problem. Examination of the patellofemoral compartment involves checking the stability of the compartment, as well as the structures, if they're loose or tight. So the first part of the examination is patellar mobility. And what you do is you just move the patella laterally and medially, evaluating how far the patella can move. And we usually cut the patella in quadrants and then base it on how many quadrants we can move the patella. So in this situation, he moves about halfway to the lateral side, halfway to the medial side. The second part of this is patellar tilt, where we try and tilt the patella. Structures on the outside of the patella tend to be tight, so if it's too tight, you get overpressure on the lateral side of the knee. So what we do is we just try and tip that up, and if we can move it to neutral, that's about normal. The next evaluation is something called a Q angle, and it's an angle between the anterior superior iliac spine to the center of the patella, that line, compared to a line drawn from the center of the patella through the tibial tubercle. Greater than 20 degrees is abnormal in girls. Greater than 15 degrees is abnormal in boys. When the tibial tubercle is farther out to the lateral side, you get a greater Q angle, putting greater forces across the patella as it moves and glides up and down. Another patellofemoral exam is evaluating how tight the IT band is. With the patient in a lateral position and their hip directly towards the ceiling, you want to look at the IT band and see how tight it is. Then we take the hip and extend it and try and drop the knee towards the table. And we want to see the flexibility of the IT band. You can see the IT band here. and that's a little tight. And then the other thing we can do is bend and straighten the knee. And if this is tight and we're stretching on it and they report anterior knee pain, that's an indication of an anterior knee problem or a problem of the patellofemoral compartment. Next examination for the patellofemoral compartment is just active range of motion in the knee. You can check the Q angle again in a seated position, identifying where the tibial tubercle is, and then just having the patient do an active knee extension. You get to evaluate their quad tone and make sure that their vastus medialis is working well. And then if we have them bend again, put a little pressure on the knee and have them straighten. That's called the patellar grind test, where by applying a little bit of pressure we can tell if they're having pain in that patellofemoral compartment. There's 4 major ligaments in the knee: anterior and posterior cruciate ligaments, medial and lateral collateral ligaments. The anterior cruciate ligament is one of the most commonly injured ligaments in the knee. It is best tested by a test called the Lachman's exam. A classic Lachman's exam is putting your hand under the femur and assuring that the hamstrings are nice and relaxed. Your thumb goes over the front of the femur, and then you pull the tibia forward quickly. The knee should be in 20 to 30 degrees of flexion, and it's just a pulling. An alternative way to do that, which is what I use more often, is just lying your leg under to allow the hamstrings to relax. Put your thumb over the patella and femur and just pull forward. And you want to feel a tight end point. If you don't feel an end point or get increased translation, that's positive for a ligament tear. A second but less specific test for the anterior cruciate ligament is called the anterior drawer test. So with the patient in 90 degrees of flexion, you support their foot, you push on their hamstrings to make sure they're relaxed, put your thumbs on the tibial plateau and just pull that forward, pulling the tibia anteriorly on the femur. Next ligament to be tested would be the posterior cruciate ligament. There's 2 ways to detect a posterior cruciate ligament tear. One is to see a sagging of the tibia posteriorly. That isn't occurring right here because we can see his tibial plateau. But if that were sagged back and this were a flat, that would be positive for a posterior cruciate ligament injury. The second is a posterior drawer test, where again you have the hamstrings go relaxed. You put your thumbs on the tibia and just push posteriorly. Next we're going to evaluate the mid and the lateral collateral ligament. These ligaments are tight in full extension as well as 20 degrees of flexion. So to do that, you want to bring the knee so it's nice and relaxed, have the patient kind of relax their leg, move it up and down to make sure they're relaxed, and then apply a force to the inside, force to the outside. Now this is a valgus force when I push to the inside. This is a varus force when I push to the outside. And all we're doing is testing the collateral ligaments. An alternative way to do that is put your leg under the patient's knee, hold their femur, and apply valgus for the medial collateral ligament, apply varus for the lateral collateral ligament. And it's important to test side to side on this test because people vary in their laxity naturally. Next we're going to go over the examination of the meniscal cartilage. The meniscal cartilage is there's a medial meniscus and a lateral meniscus. Signs and symptoms of meniscal tears are pain along the joint line, and one very sensitive test for this is actually just palpating along the joint line between the femur and tibia, which is right here for the medial meniscus. Let me bring your knee up here. And same thing on the lateral side of the knee, pushing right along the joint line. The patient will be tender usually if they have a meniscal tear. The second examination is called the McMurray's exam. You want to bring the knee up into flexion and twist the knee, applying either a valgus force or twisting the knee and applying a varus force. And all you're doing is compressing the joint on the inside or the outside. So when I do valgus force, I'm compressing the lateral joint. When I do varus force and twist, I'm compressing the medial joint. Classically, McMurray described that as a popping. More commonly, in clinical practice, it's pain in the joint where you suspect the tear. Today